Up next, we have Dr. Akilesh K, who is currently working as the Professor of Respiratory Medicine in AMRITA Institute of Medical Sciences. He is currently the NTEP State Task Force Vice Chairman of Kerala. He is also the coordinator of AMRITA Pulmonary Rehabilitation Program, and he has also received the Young Pulmonologist Award by APCCM in 2019. A very warm welcome to Dr. Akilesh.
Good evening, everyone. First of all, I thank the organizing committee of Medicine CME Update for giving me an opportunity to present in this prestigious conference. And I congratulate organizing committee for selecting these topics also. And one of the topic allotted to me is pulmonary rehabilitation in chronic respiratory diseases is one of the most relevant subject in this current scenario. I will start with a case scenario. She is a 50-year-old female, old pulmonary tuberculosis, 30 years back, presented with exceptional breathlessness for 10 years, now progress for the last 1 year and associated with fatigue. On examination, her saturation was 66%. She had a mixed respiratory failure and a moderate pulmonary arterial hypertension. She was already on all the optimized medications, and this was the chest X-ray showing a fibrobronchiectasis and hyperinflation. What we can offer apart from these medicines? This is where the importance of pulmonary rehabilitation comes in place. Now, we know standard of care in COPD management includes a proper diagnostic assessment by spirometry and assessment for future exacerbations, symptom score like CAT score, etc. Management strategy including pharmacotherapy and non-pharmacological methods like smoking cessation, oxygen, vaccination, and NIV are very much familiar to us. Adding to this is the pulmonary rehabilitation. Pulmonary rehabilitation is not an adjunct to a COPD management. It should be an integral part of COPD management. It is defined as a multidisciplinary program of care of patients with a chronic respiratory impairment that is individually tailored and designed to optimize physical and social performance and autonomy. That means the goal of pulmonary rehabilitation is not to reverse the pathogens of the disease, but to give maximum quality of life and autonomy to the disease patients who are eligible for pulmonary rehabilitation. COPD bronchiectasis before and after lung resection surgeries are absolute indication for pulmonary rehabilitation, and in current scenario, long haul COVID are also an absolute indication for pulmonary rehabilitation. There are some weak recommendations or future directions are coming in interstitial lung disease, pulmonary arterial hypertension, chronic asthma, other restrictive lung diseases including neuromuscular and chest wall diseases. Who is not eligible? Severe orthopedic or neurological disorders limiting the mobility, severe pulmonary arterial hypertension, excessive induced syncope, recent MI or unstable angina, refractory fatigue, severe peripheral vascular occlusive disease, inability to learn, psychiatric instability and disruptive behavior. In these cases, pulmonary rehabilitation may not be a good option. And when to refer a patient? Whenever there is a patient have a exceptional dyspnea or maybe because of the decreased physical activity and failure to stabilize with the medical management, and if patient present with a decrease in quality of life, increasing healthcare resources use and psychological stress, in this condition we can refer a patient for pulmonary rehabilitation. And why to do rehabilitation? We know the respiratory impairment. Whenever there is a respiratory impairment, there is a chance for dyspnea during even moderate exertion, and always there's a tendency to abstain from the exercise, which can further contribute to physical deconditioning. So even during the mild exertion, the dyspnea can be continued. This will again contribute to further deconditioning, and this will ultimately lead to a poor quality of life. So impaired gas exchange, impaired pulmonary circulation, ventilatory dysfunction, skeletal muscle dysfunction, this all can lead to exercise limitation. So we can see that there are a lot of variables can contribute to different manifestations of COPD. degree of this airflow obstruction, diffusion abnormalities, gas sustain abnormalities, ventilatory limitation, effort intolerance, peripheral muscle weakness, cardiovascular limitation, nutritional deficiency, psychological status, poor quality of life, inflammation, comorbidities, frequent exacerbation. These all can lead to a poor quality of life in case of COPD. So, what are the components of pulmonary rehabilitation? So, these are health education, general exercise training, breathing retraining, nutritional advice, psychological support, and outcome assessment. We can come to each of these components. Our center protocol means whenever a patient encountered into our rehabilitation clinic, our medical social worker will do a proper assessment including symptom score and this 6-minute walk test, pulmonary function test, psychological assessment with Hamilton A and D scale, and then the rehab physician will do exercise prescription, and we will categorize to whether the patient prefer home rehabilitation, institutional rehabilitation, and video rehabilitation. We know that in this COVID scenario, most of the time institutional rehabilitation may not be a suitable option. Then we will give limb exercise and breathing exercise, nutritional prescription, and follow up every 2 weeks till at least 4 to 6 weeks. Now, health education is one of the most important components in pulmonary rehabilitation. The patient should know about disease pathogenesis for ensuring proper adherence to the therapy. And we have to educate about optimizing their inhaler technique, also about breathing strategies, energy conservation techniques, and they should know about their exact pathogenesis, and also they have to set their goals for their future life. Also, they should be able to plan about their end of life decisions, etc. Also, how to do energy conservation and how to adhere to the smoking cessation, what are the optimal food habits, when to seek a healthcare resources, or what are the warning signs of an exacerbation, how to plan for leisure, travel, and sexual life. These are all important in case of chronic respiratory diseases management. So you can see that exercise training there are a lot of exercise trainings are there, like endurance training, breathing training, flexibility training, etc. And it's broadly it's based on the principle of FIT principle, that is frequency, intensity, type, time, and we can add that to progression. Frequency means whether it is a continuous, that is exercise at prescribed intensity for the duration of the exercise period. That means if a patient wants to exercise at 30 minutes continuously, that's called continuous training. But for severe fatigue or severe desaturation, in those cases, brief period of high intensity exercise should be alternated with a short period of recovery. Cyclical training means incorporation of cycle of training mode like flexibility, stretching, balancing, endurance. These can be mixed. Now coming to the intensity, what are high intensity pulmonary rehabilitation? Moderate or low intensity. High intensity rehabilitation means when the patient is exercising at a rate of more than 70% of the maximum exercise capacity as decided by CPET. Moderate intensity means when the patient is exercising at a rate of 50 to 70% of the maximum exercise capacity as decided by the cardiopulmonary exercise test. Low intensity means if it is less than 50% of the maximum exercise capacity. Now coming to the type of exercise training, we know that endurance training are there, resistance training and respiratory muscle training. Endurance training improve exercise tolerance, but it does not have any effect on muscle strength. Resistance training promote muscle growth. It also reduce muscle atrophy. Respiratory muscle training improve respiratory muscle strength and size. What are the recommendations for these trainings? The must to do is lower limb endurance training and home exercise program. That means even though patient is doing an institutional rehabilitation program, they should continue the rehabilitation at home. Optimal upper limb endurance training and strength exercise are optimal. Stretching, flexibility, and balance training are optional. So lower limb endurance training is the must. Now coming to the different exercise training, endurance again. What is endurance training? It is repetitive actions over an extended period of time, like walking, cycling, swimming, etc. These are rhythmic, dynamic exercises involving large muscle group. Strength or resistance training means explosive exercises over a short period of time, like sprinting, jumping, lifting weights, etc. This should be based on exercise prescription by a rehab physician. These are some of the examples of endurance training. You can see lower limb endurance training includes this walking, treadmill, stair climbing, stationary bicycle, sit and stand exercises, etc. Upper limb endurance training including unsupported arm lifting, shoulder wheel exercises, resistance training including lifting weight against resistance like ankle cuff, dumbbells, etc. Most of the time, this endurance training and resistance training can be overlapped. Positional training or energy conservation techniques, especially in severe disease patients or in post-COVID or interstitial lung disease patients, positional training may be needed. This include lying sideways, leaning forward, upright sitting in a chair, forearm support using a trolley, standing with back support. These are some of the energy conservation technique. In those patients, rollator assisted walking can be incorporated. Breathing training, this is very much popular after this COVID scenario. Inspiratory breath hold, improve lung compliance and recruit alveoli. Pacely breathing and control breathing exercises, maintain airway patency, decrease respiratory rate and dynamic hyperinflation. Diaphragmatic breathing decrease work of breathing and strengthen the diaphragm. Deep breathing exercises should be performed in cycles not more than 3 to 4 breaths. So maximum effort should be there in each breath, but we should avoid dizziness and long breath. It should be deep breath but not long breath. Adequate analgesia should be given, avoid distraction and position accurately. Benefits include increase in lung volume, ventilation, diffusion, compliance and saturation. But it decreases air resistance and dead space ratio. Incentive spirometry will be helpful to prevent postoperative atelectasis and also in respiratory lung disease with dysfunctional diaphragm or dysfunctional respiratory muscles. Also to prevent atelectasis in acute chest syndrome. Complications including hyperventilation, fatigue, pain, etc. Inspiratory muscle training needs some inspiratory muscle trainers. There is not much changes in PFT or effort tolerance, breathing pattern and respiratory muscles, but there are improvement in diaphragm and accessory inspiratory muscle function. Improvement in size of inspiratory muscle as assessed by fiber type, distribution and size. These are the some of the recommendation published in one article. But most of the guidelines, including BTS and AICVP, are not routinely recommending inspiratory muscle training as part of pulmonary rehabilitation. Bronchial hygiene techniques, including postural drainage, depends upon gravity-assisted drainage of secretions, especially if the patient is having lot of secretions like bronchiectasis, lung abscess, chronic bronchitis, postoperative, etc. It includes postural drain. These other methods are percussion and vibration, directed cuff method, forced expiratory technique, autogenic drainage, positive expiratory pressure, etc. Active cycle breathing technique. This is one of the method of bronchial hygiene technique. You can see that this breathing control for 20 to 30 seconds, then again take a deep breath, then huffing or forced expiratory technique. This ACBT technique can help to loosen and clear secretion from the lungs. Also improve ventilation in the lung, improve the effectiveness of cough. OPP devices like Acapella can be used as an adjunct therapy to conventional chest physiotherapy to promote secretion clearance. Now, what should be the optimal duration for a pulmonary rehabilitation program? A proper pulmonary rehabilitation training program should be at least 6 weeks. There are several trials undergoing for reducing that to 4 weeks. But whatever be the duration, it is better to have a maintenance phase at least at home. The longer the duration, benefit will be maximized. In low intensity training programs as in post-COVID or interstitial lung disease, the duration can be increased. Per each session, at least 20 to 60 minutes should be elapsed, and minimum 5 days per week with 2 to 3 sessions supervised. That means 2 to 3 sessions supervised, other sessions at least at home, unsupervised. Exercise prescription. This is outline of exercise prescription, and it will be based on again fit principle. You can see that in endurance training, frequency is 3 to 5 times per week. Initial intensity more than 60% of the maximal work rate. Time 20 to 60 minutes per session. It will be rhythmic, dynamic exercise involving large muscle group. Progression up to 4 to 6 dyspnea Borg scale. Resistance training, frequency 2 to 3 non-consecutive days per week, 60 to 70% of one repetition maximum, more than one set of 8 to 12 reps. Then large muscle group should be involved. So this is one of the example for exercise prescription. As per the 6-minute walk distance, it is calculated as 1280 meter in 30 minutes. We should decide whether interval training or continuous training should be there in this patient. Depends upon the dyspnea Borg scale. A few words about nutrition. Nutrition deficiency is having high prevalence and association with morbidity and mortality. So there may be high calorie requirement in those patients who are undergoing pulmonary rehabilitation program. So we should supplement proper nutritional interventions. And anabolic steroids and growth hormone does not have definite role. Positive benefits of nutritional intervention including improving the quality of life, peripheral muscle strength, respiratory muscle function, BMI, and exercise capacity. What are the rehabilitation assessment tools? There are several tools like MMRC scale, modified Borg dyspnea scale for assessing the dyspnea, and there is 6-minute walk test for effort tolerance, CAT score for especially useful in COPD for symptomatic assessment, and also for quality of life. Board index is a composite score for COPD, and you can see that this visual analog scale or numerical rating scale, Central Respiratory Questionnaire for quality of life, harm A or harm D or hospital anxiety depression scale for psychological status, manual muscle testing. These all are different scales for a pre-rehabilitation and post-rehabilitation assessment. Now coming to the disease-specific consideration in pulmonary rehabilitation. You can see in COPD there will be expiratory airflow limitation, air trapping, hyperinflation. These all can contribute to breathlessness. This can lead to physical inactivity, deconditioning, effort intolerance, poor quality of life, future exacerbation or frequent exacerbations. So what are the pulmonary rehabilitation consideration in COPD? So irrespective of smoking status, chronic respiratory failure, cardiovascular comorbidity, anxiety and depression, we should suggest pulmonary rehabilitation for all COPD patients. MMRC is at least for MMRC scale 2 to 5. MMRC 5 patient usually housebound, so it's preferable to avoid as they may not be able to cooperate with the rehabilitation properly. And MMRC scale 1 may not be able to perceive the effect of rehabilitation. Now, what intensity should be given in COPD? For moderate COPD, high intensity training have greater physiological advantages. And for severe COPD, again high intensity training is more beneficial. Improved degree of PR intervention to moderate COPD than severe COPD. So moderate COPD patient will benefit with pulmonary rehabilitation than in case of severe COPD. Now, endurance and strength training can improve 6-minute walk test and quadriceps strengthening, and combined training, that is endurance and strengthening training, can increase peripheral muscle strength, and it will also help to continue rehabilitation without increasing the duration of the endurance training. OPEP devices There are very low evidence of OPP devices used with the decreased COPD symptoms and exacerbations, but it will be helpful in chronic bronchitis variety and in bronchiectasis also. Supplementary oxygen therapy, no difference in shuttle walk test, hospital anxiety, depression scale in both group, but there will be reduction of dyspnea in oxygen group. So now coming to one of the complicated topic, that is pulmonary rehabilitation at the time of COPD exacerbation. Frequency of acute exacerbation for COPD is 1 to 4 per year, and hospitalization is 16% out of this spectrum. Decreased complaints. So what is the effect of acute exacerbation? It can lead to decreased complaints to the existing rehabilitation program. It will be again, there will be reduced gains, or it will reduce the achieved gains such as effort tolerance and quality of life, which in those patients who are already in pulmonary rehabilitation program. Again, it can increase the anxiety and depression and decrease physical activity. So there will be a tendency for lack of compliance. What is early rehabilitation post acute exacerbation? It means immediately or within 3 weeks. So ideally, we have to do at least within 3 weeks. It is shown that airway clearance technique does not show any improvement in ventilation, but it can improve secretion clearance. Early mobilization can improve shuttle walk test and health related quality of life. It can decrease future hospitalization and exacerbation. During the exacerbation, if we are giving pulmonary rehabilitation, it may not give much benefit to all patients, but we should take it as an opportunity for sensitizing the advantages of pulmonary rehabilitation. So this is our center experience in COPD cases. This is about home-based pulmonary rehabilitation. You can see that out of these 100 patients, there was significant improvement in BOD index, six-minute distance, and CAT score. Now coming to bronchiectasis. We know that bronchiectasis patients present with copious amount of expectoration, shortness of breath, and conventionally treated with antibiotics and bronchodilators. So there will be reduction of pulmonary function, excess capacity, altered pulmonary mechanics, inefficient gas exchange, decreased muscle mass, psychological morbidity, and poor health-related quality of life and in these patients. So what are the peer considerations in bronchiectasis? We should suggest moderate to high intensity exercise in bronchiectasis. At least 8-week exercise training program will be beneficial. Airway clearance and nutritional intervention are an integral part of bronchiectasis rehabilitation program. Improvement in quality of life and dyspnea were greater for patients who are younger, less severe dyspnea, and better FEV1. There will be good outcome in exercise tolerance, improvement in six-minute walk distance, reduction in fatigue, and reduction in frequency of exacerbation. Now coming to interstitial lung disease. We know that the problem with interstitial lung disease is there will be damaged and thickened interstitium. There will be diffusion. There will be reduction in the diffusion, and there will be there will be poor gas exchange, inflammation, skeletal muscle dysfunction, physical deconditioning, multiple comorbidity. This gas exchange may be due to poor gas exchange may be due to membrane thickening. Impaired diffusion will be there, and there will be poor circulation may be due to pulmonary capillary dysfunction, hypoxic pulmonary vasoconstriction, pulmonary arterial hypertension, or cardiac dysfunction. So these are general consensus regarding pulmonary rehabilitation in ILD. Type of fibrosis does not matter, whether it is IPF or any other type of ILD. The effect of pulmonary rehabilitation is almost same. Less lung damage, likely to have more impact. So it is better to enroll an ILD patient as early as possible in a rehabilitation clinic. Greater improvement in patients with less lung damage, low grade of MRC scale, high FVC, less exertional desaturation, low RVSP. Preferably low intensity training, and that also seated exercise in patients with a higher BOS score. And there is a very weak evidences in regarding pulmonary rehabilitation in ILD. Asthma. Again, pulmonary rehabilitation improve health-related quality of life, symptoms, anxiety, and depression in moderate to severe disease. It's almost like COPD itself, but we should consider for exercise in this bronchospasm, as we know that exercise is a non-trigger for an exacerbation. So Pre-exercise bronchodilation should be given. Gradual warm-up and cool-down should be done, and we should eliminate triggers, especially cold, humid, dry, dusty environment in the rehab clinic also. Now, post-COVID syndrome. In post-COVID disease, rehab is widely discussed, and there are general consensus that pulmonary rehabilitation will be an effective add-on therapy to post-COVID disease. In post-COVID, low-intensity pulmonary rehabilitation is suggested. Breath holding, ventilator training, and positional therapy will be ideal in the initial setting. Avoid resistance training initial period. We have to always rule out cardiac complications like myocarditis, pulmonary embolism, and other comorbidities also. Individual rehabilitation should be given rather than group rehabilitation. In severe fatigue, it is better to avoid pulmonary rehabilitation. No clear-cut guideline regarding the initiation of when to initiate pulmonary rehabilitation in post-COVID disease. Pulmonary rehabilitation has shown that it will improve effort tolerance, fatigue, health-related quality of life, dyspnea, anxiety, and depression. So, several guidelines suggest early rehabilitation will give meaningful outcome in post-COVID disease. This is our center experience in post-COVID pulmonary rehabilitation. That also early pulmonary rehabilitation, we can show that significant improvement in 6-minute walk distance, fatigue scale, peak flow, harm scale, etc. And we have published a case series also regarding in this. Now coming to the pulmonary arterial hypertension. The exercise limitation due to pulmonary arterial hypertension are due to abnormal pulmonary vascular response, impaired cardiac function, inability to respond to increased peripheral muscle demand under exercise, or due to physical deconditioning. So there are several trials were there regarding pulmonary arterial hypertension and pulmonary rehabilitation, because it was in severe pulmonary rehabilitation, severe pulmonary hypertension rehabilitation is not widely suggested, but in mild and moderate, it is shown that there will be improvement in 6-minute walk distance, quality of life, and improvement in WHO functional score. Now, what are the exercise consideration in pulmonary arterial hypertension? Slow incremental exercise with a short duration will be preferable. Avoid exercise which causes rapid hemodynamic changes. Exercise intensity and duration should be as tolerated. Depends upon patient symptom profile. Exercise at sub-symptom level. Maintain saturation more than 90%. Light intensity training will be preferable. Abolish pulmonary rehabilitation if there is a chest pain, syncope, palpitation, or hypertension. Pre and post lung transplant. Generally, individual treatment plan should be given as per the primary disease. Here also, low intensity training or interval training will be ideal. Post transplant, at least 4 to 8 weeks, we have to give pulmonary rehabilitation. Avoid arm activities which affect surgical healing. In this case, daily training is essential. OSA and morbid obesity. Several studies have shown that pulmonary rehabilitation and oropharyngeal exercises can have some improvement, especially with CPAP. It will improve functional parameters and also decrease BMI. And these are the oropharyngeal exercise which should be an adjunct to the CPAP therapy. And even in mild OSA, oropharyngeal exercise alone can improve functional parameters. Now, obstructive sleep apnea is nowadays considered as a new indication for pulmonary rehabilitation, which can have significant impact in dyspnea, fatigue, and the psychological status, etc. Neuromuscular disease. The issues with neuromuscular disease is maybe due to bulbar dysfunction and chronic or recurrent aspiration, or maybe due to inspiratory muscle weakness. The concerns are that the traditional program may not be optimal. Depends upon the disease spectrum. We need to tailor the rehabilitation protocol. Individual treatment plan should be designed. Aerobic plus strengthening training there is only level 2 evidence. Inspiratory muscle training should not be given, especially to hypercapnic patients and also patients with FVC less than 25% predicted. Measure CPK and urine myoglobin in muscular dystrophy. Assisted walking and devices like rollator, NIV and cuff assist devices will be helpful in PAH. In neuromuscular disease. Measurable improvement in quality of life and sleep and fatigue in case of this neuromuscular disease. Now, lung cancer, it can again improve exercise capacity, fatigue, endurance, psychological status. Need to modify rehabilitation around chemotherapy, pre-lung resection surgeries, daily session for 2 to 4 weeks can be given. No clear-cut guidelines. This is also an upcoming field in case of lung cancer. And this is our rehabilitation clinic which we started in 2 years back, and this is the protocol what we are following with all the vitals, vaccination status, smoking cessation strategies, functional parameters, and we have as per the exercise prescription we are devising or designing our rehab protocol. I am concluding the session with one or two case scenarios. You can see that it's a 50-year-old male with a COPD. Pre-rehabilitation, you can see that MMRC, CAT score, saturation, ABG, six-minute distance, psychological status like harm score, everything is improved, but there is not much improvement in FEV1. This another case, as we told earlier, regarding that all PTB patient, you can see that the baseline saturation was improved. ABG, walk distance, CAT score, HAM score, everything, every parameters were improved post rehabilitation. So, pulmonary rehabilitation can be considered as a comprehensive therapy with much focus, but not exercise alone, to improve quality of life and patient's independence. Lower limb endurance training is essential in most cases. Proper exercise prescription will be ideal to ensure efficacy and safety. Pulmonary rehabilitation can give hope in various other chronic respiratory diseases other than the conventional COPD and bronchiectasis, but more evidences are to be generated. Thank you.
Thank you, sir. Thank you, sir, for that wonderful talk. Very useful in this session where there is a lot of post-COVID sequelae and post-COVID complaints in the community. So a few questions, sir. One is, what is the impact of rehabilitation in spirometry in COPD, sir?
Yes. Okay. Usually the concept of rehabilitation to improve this health-related quality of life and psychological status, etc. It does not reverse the exact pathogenesis or reverse the disease process itself. So it does not have much impact on most of the spirometric variables in most of the diseases. But occasionally we have seen in some cases there may be some spirometric improvement, but we don't need to focus on spirometric improvement, but we have to focus on more on effort tolerance, 6-minute walk distance, and other quality of life parameters as well.
Okay, sir. Any precautions to be taken in post-COVID rehabilitation, sir?
Yeah. In post-COVID rehabilitation, mainly we have to start with low-intensity pulmonary rehabilitation training. If possible, preferably, especially very severe dyspneic patients, first we have to rule out any other comorbidities like cardiac complications like myocarditis or pulmonary embolism. This has to be kept in mind, and we have to rule out all these diseases itself. If there is a severe fatigue, it shows there is a high level of inflammation. In that scenario, rehabilitation is not so indicated, and other psychological assessment and everything to be done. Preferably seated exercise seated exercise can be done for post-COVID patients in initial period, rather than focusing on this quadricep strengthening training. In initial time, we can concentrate on the ventilatory training like breath holding, pacely breathing, diaphragmatic breathing, etc. in this post-COVID scenario.
Okay, sir. Thank you, sir. One thing nowadays, when we sit in the OPD, I think more than 50% of the people we see are post-COVID. So for those who were actually severe disease, who required NIV and all during their stay, the duration of antifibrotics and all, whether there is single or a dual, that has always been a controversy, whether a single or dual antifibrotics is required, when that can be stopped, and what is that impact of it in rehabilitation, sir?
Yeah, antifibrotics, there are a lot of controversies regarding the role of antifibrotics in post-COVID lung diseases, because in some subset of patients, there is no need of antifibrotics, and sometimes patient this fibrosis can recover over a time. But other cases, there is no clear-cut recommendations or clear-cut duration for how long you have to give antibiotics. Depends upon severity and other parameters like oxidation parameters, walk distance, and other like that. So there is no exact duration and when to add a second antifibrotic, and that we have to check for adverse events, their improvement, etc.
Okay, sir. Thank you for the insight on this topic, because as COVID is going up, I think it has a very big role in the management of respiratory diseases in the community, sir. Thank you, sir.
Thank you.